Thank you very much, Dr. OLWENY. I think you have put things in very good context and perspective. Let me just ask two clarifications. On the matter of commodities, especially on the matter of making it, you find that you gave the example yourself. A drug you're buying here for 3,000 shillings, same drug in the next country is a fifth, quarter of the price. You find that you can buy Panadol at 20 shillings in one facility. The same Panadol, you buy it at another facility, or you get it at another facility and you are charged 50 shillings. So, what is the remedy in your opinion, and who should do that? Is it, do we find a place? Is it a combination of Kenya Medical Association, medical practitioners, private people, and government to standardize that particular subject, so that, because a big contributor to the cost of health is that disparity in how much it costs, the commodities cost. That's one. Where would you what suggestions do you have on how we can fix that? That's number one. Number two, you have given two suggestions on mobilizing, and I think you have suggested that pooling is the most effective or efficient way of delivery, and pooling can either be through a tax system or a social health, as we are proposing. Do you have any suggestions on what Kenya Kwanza can do? Would you say the social health would be better than the tax system, or what suggestions do you have? And then finally, in terms of, and I hope I'm not loading too much into your plate, you also talked about a fixed cost approach. Can you elaborate there? I didn't quite follow it properly. You know, the two suggestions you made. I think what preference would you think we should go?
Okay, so firstly, with respect to the prices of the commodities, first of all, there are various dimensions. We have to understand, first of all, that we are comparing apples and apples, not apples and oranges. So in terms of, first of all, control in terms of quality, that role falls, for example, for pharmaceuticals with the Pharmacy and Poisons Board. We have got drugs that are branded drugs, we have got drugs that are generics. The key thing for healthcare providers, and I talk about as individual practitioners, we want to be sure that we're getting drugs that are of good quality. There are times the drugs have fallen short. And as a doctor, you want to be sure you're giving your patient the best. So first of all, in terms of ensuring that all drugs on our market, first of all, meet the quality threshold and they work. If that happens, then now we can prescribe the cheapest one. And that, of course, is one of the ways of exerting pressure on those guys who are overpricing their products to bring those prices down. In India, for example, they have got the volumes. And they told the big manufacturers, if you want to be able to access our market, you're going to sell it to our clients at this price. Kenya can be able to do the same, because guess what? In this region, you've got drugs that are being sold, same drugs sold in Uganda and Tanzania at a lower price, because the feeling is Kenya is doing better economically, we can charge a premium. And so sometimes they even stop people from getting products across borders by changing the name or changing the packaging, so that it says this was for the Tanzanian market and this for the Kenyan market. But it's the same drug. So that's why I'm saying government has to play some hardball here, because at the end of the day, we are not going to bring down costs of healthcare if this component that is 30 to 40% of the bills is not managed. So if we can be able to enhance our manufacturing sector, because we also have a manufacturing sector in Kenya that needs support, and especially for basic drugs that are not too complicated, and consumables and other products, if we can be able to boost that sector. And that's why I was talking about the incentives for the health sector. If we can be able to produce our own, then now we have got some that we can also be able to compare with others and make sure that people charge a price that makes sense. The other question, sorry, I've even forgotten the second question. It was relating to...
whether we do tax or we do social...
In terms of being able to finance the financing, the pre-financing of... I think at the moment the truth is we're actually doing a mix of both.
Yeah.
If you were to ask me, you know, the danger sometimes with the essential services is governments don't want to divest totally from them, because sometimes the private sector can be able to arm twist, and you might have a certain segment of the population not being able to access services. So in our situation, I think at the end of the day, government health facilities must be there to a certain extent. Because again, the private health sector you find in certain far-flung regions where it might not make economic sense, you'll not find people willing to invest in those areas. So, but at the end of the day, the social health insurer is the best option. The reason is, number one, it pulls a large number of people together. Already we have got a regime where it is mandatory, especially for those in formal employment. You don't have a choice. Whether you have an alternative insurance or not, you already don't have a choice. So there's already a significant pool of money which is coming in regardless. But in terms of the efficiencies of that social regulator, that has to be. There was a time when there was rumor that their management costs were going close to 50%. Of later here, now it's come down to the tune of 20–15%, which is more manageable. But in terms of being able to structure and reorganize those organizations and make sure that they're delivering on their objectives is important. There was even talk once of being able to segregate the duties of the payer and the people who are providing the benefit package in that sense. So those are proposals that are there, but in general, the social health insurance way, I think, is the easiest way to go. It's the easiest way to go, but it has to be within very good and strict controls. Now,
I think the framing is correct.
yes.
Do we do fee for service, or do we go the capitation route, or there is room for a mix?
There's actually room for a mix. Fee for service has got certain dangers. And this is the reason why even you find, for example, when the NHIF rolled out the certain schemes that they have, when you've got very large numbers of claims, as numbers go up, those administrative costs of vetting claims, managing them, and paying them becomes extremely high. So what happens is that's why people want to move towards a capitation model. Capitation has got dangers, though, because you can have healthcare providers doing what you call skimming. If you've got people whose health needs are going to be high, the tendency to avoid registering those people in your facility. Now, we can go towards a value-based system, and that's the merge somewhere in between, where what, for example, we are saying is we are paying you for a product you're delivering. So it's a value-based system. The danger with the fee for service is that the tendency is the healthcare providers are an interested party. There's churning. The more service you provide, the more you get paid. So you see there's a tendency to waste resources. So, and you must remember, there's also that agency relationship. There's a bit of a mismatch, because there's also, you must remember, there's also the asymmetry of information. Health is a pretty specialized area, so you've got to take our word based on what we recommend and what we do. The question is, if I'm an interested party, am I providing you the best care, or am I providing the care that's in my best interest?
Listening to you, Daktari, we are a value-based system. Did you say that? Which is midway between capitation. Capitation, the temptation will be you avoid people who you think they will take more from your service.
Yes.
The other one, you will give, you will be too generous.
Yes.
Because you want to be paid.
Yes.
You know? So we must find an in-between.
Sometimes at the end of the day, and this is what sometimes at the moment you can say diagnosis related groups. For example, we say, instead of talking about this, we'll say for this particular service, we'll pay you X amount, and we agree on that charge. In fact, the truth of the matter is it forces people to be more efficient, because now it means that I'm going to provide that service as a fixed cost. So there's interest in me lowering those costs. So over time, you might find the costs of delivering service actually go down within a country. So there are very many mixes in between. I gave you the extreme ends. Capitation, the biggest problem we had, like with the NHIF system that was introduced for capitation, the rates were ridiculously low. Ridiculously low. Because you cannot talk about taking care of the health of somebody at 100 shillings a month. It doesn't matter how those numbers add up. For 1,200 bob a year, most people are losing money. And that's why you find a lot of healthcare providers are going to run away from it. Yet in the government, you can go to the government health sector, you will get the service, so to speak, but the commodities are lacking. So there's no point in going to be seen by a doctor and get your diagnosis done, so to speak, then there are no drugs. After that, you're told, go and buy the drugs from a pharmacy. So there's a lot of work to be done, and I believe, especially now that the conversation is happening, there's ways in which we can make our healthcare system more efficient so that we don't run in a situation like the US where you're spending so much per capita and you're not really getting value out of it.
Thank you very much. Because you are very resourceful, I want to get as much out of you as possible.
Okay.
Before you leave. I want you to just react to two things in terms of what you have said, and this is, you can see the direction we are thinking, and you probably have more conversation,
yes,
but so that they can be discussed later. One is procurement. On the question you raised about procurement, and the cost of commodities, and the choice of commodities, about the efficacy or the practicality of a stakeholder-owned or managed national procurement sort of platform. The idea here being, something we've been doing with petroleum, which is different from the subsidy that's gone wrong. But at some point, we got all the petroleum companies to come together, and they decide what quantities of oil they need, and then they pool their needs for that particular period, and they get one of them to put out a tender. And actually that brought the costs quite down, and then you pool, so it's a pool system.
Yes.
And we're wondering whether that can work in the healthcare system, where both public and private, all the health providers, there's a platform, and we say we need so much of this antibiotic, my need for this antibiotic is so much, my need for this suspension is so much, my need for this whatever is so much, and then you come up with a procurement plan and you decide who procures what, so that you can bargain for better prices. That's one thing I want to, that's a direction we are thinking.
Yes.
And that would be part of our way of solving the cancer problem. Because then when you bring in the private, you got yourselves in there, then your interest will be such that you will want to get the best products at the best price.
Yes.
That's how we think we can discipline the public system, to be honest. That's one. The second one is between the capitation and the fee for service, about the option of a tariff system, where you have, for the social health insurance package, it has a tariff, where for every protocol that is provided, and it's agreed this is the cost-based, and you have a tariff for every protocol, and there is a system for you, for the system you setting the tariffs, so that as costs change, maybe they are adjusted quarterly or semi-annually or whatever. Would that sort of be a good halfway house between the pure fee for service, which is determined discretionally, or capitation?
Yes, okay. Yeah. Thank you for those questions. Now,
can I add something before you answer? Or you answer that?
Okay. Yes. So in terms of the bulk procurement, those are proposals that even as a private health sector we have had in the past. The challenge we have is we have, first of all, a very diverse group of organizations with different capacities. And I'll give you, for example, the so-called Big Five. They feel they've got a sufficient base that they can do their procurement on their own. So interestingly, they're actually the ones who procure at the lowest price and actually charge a premium, all right? And whereas sometimes those who are smaller cannot organize themselves sufficiently, and because of issues of cash flows and so on. So that is a very good proposal in terms of being able to bulk procure, because again, we cut off the middleman. And the bulk of in this supply chain here, the middleman is the one who is making most of the money. Facilities themselves, by the way, have got a fixed percentage that they're supposed to mark up their products. So at the end of the day, it's not going to necessarily change how much they make. The truth is the benefit will be passed over to the patient. So those are very good proposals. Originally, we have got other organizations that actually procure in bulk. The challenge is the supply is so erratic that they cannot supply us efficiently. You will put in an order and all the items are out of stock and so on. So for example, but those are very good proposals if we can get, and this way I'm saying the role of government can come in. In terms of the issue of pricing, the tariffs, even with NHIF, the current discussions that we have been having, which hit a stalemate, as you're aware, on many occasions, with, for example, the private health sector and the faith-based sector, we have got proposals that we have got certain tariffs that are supposed to charge fixed rates for certain, especially surgical packages. Dialysis was a big issue, for example. The only challenge that there was is they were pricing them below market, to the point that we would not be able to deliver the service. And that is where now the stalemate comes in. NHIF should be able to provide care, first of all. They cannot discriminate against members. You cannot be told, for example, that if you've got another form of insurance, now we're not paying for you. You should pay to the extent that they're entitled. In fact, people should go to facilities based on the choice. There are certain facilities where you'll go and pay nothing. There are other facilities where you go and co-pay, but that is a choice the person makes. For their members, there have to be facilities where they go and provide all the service. The only challenge was, when they were, for example, for dialysis, they were paying 9,500 shillings per session twice a week. Now they wanted to change it to 6,500 3 times a week. But the 6,500 is not enough to cover the cost for one session. So guess what? And they were saying you cannot charge anything other than the 6,500. What that was going to do is lock out all the people who are getting dialysis service and now actually have to pay for it cash. And they were saying, why are you giving us 3 sessions a week? Most of us are okay with the 2 sessions as long as we don't pay anything. But if you say we are paying 3,000 a week, 3,000 per session, it means now I'm going to my pocket 6,000 shillings every week. Already people who have got dialysis with chronic illness are already so cash-strapped that you cannot again put that premium on them. So that's one of the challenges. When, for example, we were told that you need to pay, to do cesarean sections for 48,000 shillings and not charge anybody any in addition to that, the medical board alone says doctors are supposed to charge 60 to 100,000 shillings. So how are you telling us we're going to charge 48,000 shillings for the entire procedure inclusive of doctors' fees? So these are the discussions I'm saying that need to be rational. So let it be that if NHIF says we can only pay X amount, let them pay that and allow the people who are going to top up, especially going to private facilities or high-end facilities, do that. But for government facilities, NHIF should be able to cover the full bill for the patients.
So